everyone. Thanks for joining today. I've been very much looking forward to this conversation and to be able to highlight the great work of our panelists and hopefully share some new information with you all as well. I'm Erin Jackson Ward, and I oversee a grant-making body of work at Cedars-Sinai, which is a hospital in Los Angeles, and my work focuses on supporting homelessness among other health-related issues, and I'm going to be your moderator for today. As you all know, because you chose this breakout group, the next hour is really going to be to learn about important considerations when providing care for the unhoused population or people experiencing homelessness. We're going to take a closer look at different approaches happening in Los Angeles County specifically, because that's what we represent up here. So we have three panelists today who will share with us the various models of care that exist, as well as some promising practices for consideration. So just to know who you're hearing from very briefly, going down just in order of how we're sitting. Dr. Coley King at the very end is the Director of Homeless Services at Venice Family Clinic, which is a federally qualified health center in Los Angeles. He's been there for the last 15 years, I think. And he's become known as a major influence in Los Angeles when it comes to advancing street medicine, and is even the architect of Venice Family Clinic's renowned street medicine program, which you will hear more about directly from him. Through his work, Dr. King has trained countless residents in this practice of street medicine and is currently spearheading an effort to develop guidelines that will help more providers adopt this approach. Thanks for joining us, Dr. King.
Thank you.
Next up, we have Brett Feldman joining us, who is the director and co-founder of the Division of Street Medicine at the Keck School of Medicine at USC. He's also an assistant professor of family medicine. Brett's been practicing homeless medicine since 2007. And he has also founded a couple street medicine programs, one in Pennsylvania, another now in Los Angeles. He's the outgoing vice chair of the Street Medicine Institute, and his primary role day-to-day is to provide technical assistance and consultation on the topics of social teaching of street medicine, program development, and optimization. Brett's work has been featured across multiple news channels, including CNN and Telemundo, and one of my favorite things that I learned is that he's even an Emmy Award winner for a PBS documentary that he was featured in 2018. Last but not least, Cynthia Carmona, right next to me, is joining us today as the owner of Carmona Insights, a healthcare consultancy specializing in Medi-Cal and the safety net. Prior to launching Carmona Insights, Cynthia led the Safety Net Initiatives Department at LA Care Health Plan, working with the county and community health clinics on enhancing systems of care. She also oversaw CalAIM Enhanced Care Management and Community Supports implementation, which will be apparent when you hear her speak to the role of CalAIM. And prior to joining LA Care, Cynthia was the Director of Government and External Affairs for the Community Clinic Association of Los Angeles County. We have representation in the audience today. And she holds a bachelor's degree from UC Davis and a master's in public administration from USC. So,
I didn't know you were charging.
yeah, some USC connections were just made. So with all that said, hope I got you even a little more excited to hear from them. I'm going to do my best to kick us off by sharing a little bit about what's happening in homelessness in Los Angeles, as well as discuss the work that I oversee at Cedars-Sinai in terms of how we support organizations serving the unhoused. And then we'll dive in to hear a little bit about each of the panelists. We have short presentations from each of them to share their role within the homelessness ecosystem. We'll have a brief discussion among us, and then we'll take questions from the audience. I really encourage us all, please feel free to engage. We want it to be conversational. And even though we all represent the LA voice, this is very applicable to anywhere, and so just remember that, even though it's LA heavy. And before we get started, just so I can figure out who is in the audience, please, with raise of hands, who is from Los Angeles? How about Southern California also?
Wow.
Okay, Northern California? Cool. Elsewhere? All right.
Central Coast.
Central.
Yeah.
Okay. How about out of state?
Oh,
Okay.
nice.
We got a couple.
What state? Oh, wow.
Welcome. And then how many of you are working directly in homeless services or housing? Okay, a couple. What about government? Other non-for-profit type of work? Okay, all right, so it really is a good mix. Can't necessarily cater to one group. Thank you for playing my game. So to get us started, and I did say I wasn't gonna stand, but I think I'm gonna stand here. I'm warning all of you. My breathing is heavy because I'm almost 8 months pregnant, so I'm gonna be okay, but don't.
Sit down when you need to, yes.
Yeah, yeah, we got some clinicians to help. No pressure.
We can call 911. Just like anybody
No
else.
deliveries.
We do street medicine only.
So welcome, officially. I did all this. Okay, you can all see that, okay? Great. So, to get us started, just to kind of position the need, as you can see, in 2019, over 58,000 people were reported experiencing homelessness in LA County, which represented a 12% increase from the previous year. Meanwhile, cuts in federal funding, a fast-growing community of older adults, rising cost of housing, substance use disorder, mental health challenges, the affordable housing crisis in general, all kind of coalesced to further accelerate LA's homelessness crisis in the more recent years, as you can see in the graph, both at the city and county levels, which are represented here. And I realize that you're pretty far, but the numbers at the bottom are representing dates. And just as a note, the gap in data in 2021 was due to COVID precautions preventing the homeless count from happening, but the estimate in 2022 was that there are now over 69,000 people experiencing homelessness on any given night in Los Angeles County, and we actually just wrapped up the homeless count at the end of January, and so we'll have more data for 2023 in the coming months. But what does this have to do with Cedars-Sinai? Because that's the voice I'm representing today. As I shared briefly, I have the privilege of overseeing what we call the Community Benefit Giving Office at Cedars-Sinai, which essentially serves as a separate foundation, even though it's part of the hospital, in which we give grants to local nonprofit organizations addressing health-related needs. And while it's not uncommon for hospitals to give grants in this way, Cedars does stand out in terms of the breadth and depth of the work, which is why we have the opportunity to partner with more traditional foundations in addressing some of the hairiest societal needs. So at Cedars, we've been supporting local organizations over the last 10 or so years, but have only really started intentionally digging into the homelessness space since 2019, which is why on the last slide that date is significant to me. Primarily because it really became a priority for the hospital, according to a needs assessment that we conducted a few years ago. And so the early days of our giving were really focused on supporting local mental health organizations. It later expanded to include establishing an initiative around community clinics. We also do some civic engagement work, as you can see on this slide, but a majority of our funding over the last few years has really been focused on homelessness. And so in terms of what that looks like more specifically, we have these kind of 4 main pillars that drive our homelessness grant-making work. As a healthcare provider, we'd be remiss not to acknowledge the bridge between housing and health, and specifically some elements of CalAIM that are focused on providing opportunities for housing service providers to tap into some additional funding streams. So we're committed to supporting grantees through that channel and kind of in navigating that new terrain, which you'll hear more about when Cynthia speaks. Additionally, when we were first conducting the landscapes to inform some local gaps in funding, we identified 2 specific populations that came up as having a great need. One of them was older adults, and the other was youth, who are both often really overlooked when homeless systems are being designed, kind of leaving their unique needs excluded. And then the last piece is around workforce, and not only there being a need to ensure equitable support for frontline workers that have a very high turnover rate, but also focusing on workforce as a method to prevent downstream homelessness. by helping folks really retain family-sustaining wages and jobs. And so across these 4 areas, the various approaches to serving the unhoused that the panel is going to discuss in a bit, all of that kind of applies, but those are Cedars-Sinai's current strategies around funding. And then here's just a quick snapshot of our growing investments over the last few years. As you can see, we were really funding some kind of one-off homelessness efforts prior to kind of the initiative launch in 2019. But it's a visual depiction of what I was saying in terms of the funding really taking off. And you can also see the split on the right-hand side for the categories discussed. And then just to kind of close it out and concretize what some of the grants look like, while also trying to smoothly transition us to more of the street outreach conversations. Here are 2 grant highlights from the last year. As part of our focus on bridging homelessness and housing and health, we supported our close partners at Venice Family Clinic to expand their tried and true street outreach work that's led by Dr. King by donating a mobile medical unit in addition to $1 million through a grant to further build out their operations and connect people to both homeless and healthcare services. And then also on the right-hand side, in recognizing that there are multiple ways to reach people, we also funded Healthcare in Action, which is a medical group that basically provides care specifically to older adults and other subpopulations of the unhoused through another street medicine approach. That grant was $500,000 to essentially help launch a new street medicine team in a part of Los Angeles County that they hadn't yet reached. And then some of the funding also went to develop a roadmap for future expansion of services based on regional needs kind of driven by the county data. So with that, that's a little bit of the grounding. That's how I'm involved with this work. I'm going to hand it over to each of the panelists to share a little bit more about their work before diving into the questions. We're going to kick it off with Brett, who's going to describe the basics of street medicine and how it can improve outcomes for this population so that we actually get into the meat of it.
Okay. All right. My name is Brett, and I have a confession to make. Hi. I'm not a policy person. I'm more of an enthusiast. And some of my very gracious and patient teachers on policy are in the audience, so thank you very much. But I've spent most of my time since 2007 under bridges and outside and things, and really started getting involved in this because we were noticing just a massive difference between benefit eligibility and benefit access, where people, were insured and covered, but they weren't able to access these benefits. And then we got a call about AB 369, and I see Elizabeth is here, which was the Street Medicine Act, and which eventually, as you guys may know, made it through the Senate and the House, then it got vetoed. And it was the best thing that could have happened, because afterwards we started working with DHCS, and they have been a pleasure to work with, and I'm not kidding when I say that. And now most of the things that were in the bill has happened. I'll get into that a little bit. And we've become friends, so it all worked out. And what I've learned from all of this is that with street medicine and everybody involved is that there has been a very firm commitment that we're going to address all of the drivers of suffering and poverty that are afflicting the people that we're trying to serve. Of course, there's the material poverty for want of housing, and there's some great people building housing, but there's also the poverty of health, the physical comorbidities, mental and substance use disorders that if not treated now on the street, can't wait 6 months for housing, will prevent them from ever walking over the threshold into housing. And if not done well, will prevent them from keeping it. But even though they have nothing, the worst poverty of all is the spiritual poverty of feeling unwanted or unloved by anybody. A poverty only deepened every time a community member calls to have one of their neighbors' encampments moved, and they get pushed around the city that they call home with no place to put their physical body. and their spirit broken, or every time a neighbor locks a restroom on another neighbor, forcing them into the dehumanizing act of open defecation. But I believe that we've been called for more, which is to love and to be loved. And so in street medicine, we go to the people with humility to first deliver that tender love, and then the same quality of care on the street that you would expect in a brick and mortar clinic. And so when we talk about street medicine, it was actually defined in one of the all plan letters very well, but it's direct delivery of healthcare to the unsheltered population in their environment. So the care is literally delivered on the street. This is done through walking rounds. We have a pickup truck and backpacks. We dispense medications out of those backpacks, draw labs, we do ultrasound and EKGs on the street. And there's a number of reasons why it has to be done this way. One is financial, and of course, we won't go into all of this, but when I say financial to a room full of medical folks, they think insurance. This is not the problem. I have a friend that does street medicine in Dublin, Ireland, and they have national health insurance. Everybody is covered there, and they did a study, and there was no relationship between coverage and access to care. This is one of opportunity cost, where we know, we do a lot of surveying at USC, that outside of Skid Row, a lot of folks are getting 2 to 3 meals a week. And they're getting those meals because they buy them. So if they're going to panhandle and choose, should I eat one of my meals or buy the bus fare to the PCP, I bet we can pick what they're going to choose. There's environmental and social barriers to know if they leave their encampment to go to the DMV or their PCP or their job interview, that everything will be stolen because it's happened so many times before. Or competing priorities for basic survival needs. So if you don't know where your next meal is coming from and where you're going to sleep tonight, if you're going to be safe doing those things, you can't possibly begin to think about things like your health care. And then finally, one that we forget, which is the wait times exceeding their planning horizon. So even if we reach our goal of giving them an appointment within a week, if because of the chaos of the streets, their planning horizon is only 2 days, they're going to forget about it. And so if we're going to be providing care on the street, we have to think about what's our scope of practice. And so at USC, and we're not the only folks doing this by any means, it's full service primary care on the street. To do good primary care for this population, it means also taking care of their behavioral health, and we love using long-acting injectable antipsychotics, and Nicole does that too, as well as MAT on the street. I already mentioned drawing labs and dispensing medications. These are just, this is Dr. Olson doing an ultrasound on the back of a truck bed, so you can try and visualize it. And then on the right is one of our PAs, Corinne. This was a gentleman who, any story I tell, the folks have given permission for me to use their photo, by the way, but he suffered from substance use disorder and was muscling, so injecting into his hip. It got infected, he required surgical debridement, and he took 8 needles out of his hip. And recommended a wound vac. So for those of you who don't know, they actually stuff it with like the styrofoam thing and put a vacuum and to approximate the edges, which is usually done as a nursing home. And he was not interested in that, so we changed his dressing every day. And between our team and also him doing his best to keep it clean, it eventually healed. And I also think it's important to distinguish street medicine from mobile medicine. This is from National Healthcare for the Homeless to show that this is a continuum. And please don't misunderstand, I am in no way putting down mobile medicine. I've worked on units in Pennsylvania. Coley has a unit. It absolutely has a very valuable place, but it's just not street medicine. One, the care is done in the unit. The other, the care is done on the street. But there's also a very important philosophical difference that I think is important, where in street medicine, we want to be able to suspend our reality and meet the people in their reality where they feel most comfortable, to intentionally flip that power dynamic in their favor. Even if we drive in proximity and take them out of their environment into ours, we flip that power dynamic back into our favor. But to fully understand street medicine and what we do, of course, there's the care for the individual, but there's also our role in public health and housing. And I think this was really highlighted during COVID, but it's something we've always done. We're always managing lice and scabies outbreaks A few weeks ago, we had a typhus outbreak in LA. There's also monitoring for food and water safety. So I mentioned, knowing that a lot of our folks are only eating 2 to 3 meals a week is a very important thing. And then finally, personal and encampment hygiene. So we know that 85% of our patients are forced into that dehumanizing act of open defecation, which has not just human dignity impact, but also public health consequences as well. We've found that street medicine is a great catalyst for housing, where medicine is seen as an instrument of peace, where we, just like the Red Cross or Doctors Without Borders, can go into these war-torn areas and be seen as somebody being there to help. And so we work with our community partners. We keep them engaged while they're waiting those months for housing and get good housing outcomes. So 38% of everybody we saw last year wound up in housing. I would be remiss if I did not mention very quickly some of the policy innovations that has made street medicine very possible. When I moved to California, there were 6 programs in the state. We did a landscape analysis of street medicine with CHCF, which should be published soon, right, Dama? Dama's reviewing the final. There was 25 programs last summer. Now we run a California Street Medicine Collaborative, and there's almost 60 programs. So some of the things are, street medicine can now be billed. They extended hospital presumptive eligibility to the street. An all-plan letter defined street medicine and made us direct access providers. So regardless of assignment, we can still order things that the patient needs, regardless of their PCP assignment. CalAIM and PATH funds some of the non-clinical staff, because we have higher non-clinical staff, non-billable staff needs than a clinic might have, and HIP incentivized health plans to want to work with street medicine. And so it's a very exciting time. There are still challenges, and these are almost inherent in the model. It's nobody's fault. And so how do we cover our public health role? When we go into an encampment, we can't just treat the scabies of the people that with the insurance we like. We have to treat everybody's scabies. So how do we pay for that? We don't pre-screen when you work in a clinic. You have fairly good confidence that whoever is coming, you've already screened their insurance, and you're going to get paid for them. We just see everybody. Their relative risk score is over 6 for 100% of the patients. That's just for the homelessness. If it goes up when you add other comorbidities, there aren't, when you do the risk adjustments, you have some with high risk, some with low risk, and it all evens out, but street medicine is all high. Go ahead.
For those of us not familiar with that risk score, can you give us some perspective on how that rates?
Sure. It's their risk of illness or death. 1 is average, so this is 6 times higher. And we treat first and ask questions later. So we don't pre-screen your insurance before we start treating you. And then the team makeup, we travel together. So when we're in a typical clinic, if you have somebody doing housing navigation, community health worker, and rooming, and that takes an hour for them to work with the benefits counselor, during that hour, the doctor can see 4 people, but in street medicine, we're all together, seeing the one person. And then the CHW, for our team, it's somebody with lived experience in homelessness that knows the street better than anybody. So they become a limiting factor in terms of maybe we'll just send out the housing navigator, but we need an extra CHW to do that, and that increased the cost. Since this is insured, the uninsured, and this is, I'm getting to the end, I promise. I hear a lot of statistics on how many people experiencing homelessness are insured, and this is mostly from a system standpoint. How many have come into our system that are insured? The street tells a different view. So our, 43% of the people that we see on the streets don't have insurance at the time that we meet them, and it's a Herculean effort to get it. And then finally, I know that we're all thinking, well, how do we solve homelessness? And I don't know, but I can perhaps give us a different place to start. And we start with the NIMBYs. Since I've been here, I've heard a lot about the encampment removals and things like that. But those are the people that say, not in my backyard. Take them out with the trash that they brought in. And we will say, yes, we agree that we cannot tolerate homelessness in our backyard, but we have to separate the person from their housing status. To hate homelessness with everything that we have, but to love the person even more than that. And so what we're seeing is that by only focusing on the housing in that context, we're actually forgetting about the person. And so how do we measure that in these outcomes, right? And so this is one of our dear patients. We finally got street medicine brochures printed, and God bless him, he cut out our pictures and put them on the wall. And I was like, why'd you put them on the wall like that? He's like, people have family pictures on their wall. You guys are my family. So we can't measure that in the outcomes, but it's more important than any statistics we can show. And these are just some videos that I thought you'd be interested in seeing. The last ones are our Invisible People video that CHCF, Dalma gave a little dance. They funded these videos from Invisible People, but it looks at street medicine across the state. Thank you.
Thanks, Brett, for really centering the people. Dr. King, would you like to sit or stand? I can give you, okay.
Right over there.
All right, we'll now hear some more about Dr. King's perspective with Venice Family Clinic.
Hi, guys. How's it going? This is well into the morning. Is everybody still awake?
It's after lunch now.
It's after lunch now, isn't it? So, hi, I'm Coley King I'm a street medicine doctor from Venice Beach. That works. So let's just talk a little bit about Venice Clinic and kind of show you a little bit of how we've grown through this. So we recently merged with South Bay Family Healthcare. So our area now has expanded to SPA 5 and SPA 8 in LA, but a big giant area of LA, of Los Angeles. But we really kind of heavy focus still on the west side of Los Angeles. So these numbers kind of come and go through time, but of 40,000 people that we saw, unduplicated folks, we saw more than 4,000 people experiencing homelessness in 1 year. And in our various outreach teams, we saw up to 3,000 people in 1 year. So as a community clinic, we can see a lot of volume of people. I don't know that each one of them we saw as a cohesive team, but our reach is out there to see a lot of folks, and then we have a lot of teams that can really see them very closely. We have, obviously we're an FQHC, we have comprehensive primary care, we have substance use treatment. We've become, very, I think, hopefully progressive in getting buprenorphine and other medications out to patients that need it as medical prescribing providers. Mental health services as a clinic, but also as street medicine clinicians and street medicine docs, we've ventured into what we're going to call bridge psychiatry, where I'm a primary care doctor, but I'm diagnosing and treating bipolar and schizophrenia and starting patients on medications, knowing that I look left, I look right, there's no psychiatrist behind my back. Now we have more street psychiatrists out there. Now the word street psychiatrist means something, so that's kind of cool. Venice Clinic has vision services, dental care. We try to do a lot of services and get everybody, all that stuff in-house. HIV team, treating a lot of patients. We're now treating a lot of Hep C, and in street medicine, we're now prescribing but not dispensing the meds in street medicine for Hep C. Health insurance enrollment, they have to have a team for that now. It's good we have one. I wish it were a little bit easier. Health education, we're giving out food. Our pharmacy is a big deal to handling this population, is a pharmacy that understands our population and has a fund for patients before they get their insurance, and I can send this down to CVS or what have you, and we have a little fund. They call it Coley Bucks. So they call me up and, do you want to use Coley Bucks on this one? And I say, yep, let's get them the med. First, I ask how much it costs. If it's $1,500 a month, yeah, I'm not kidding. We say, let's find a substitution, but DV counseling is a big deal at our clinic. So I think Venice Clinics, it started in the early 70s, and it did homeless healthcare before it was called homeless healthcare. It's a community clinic and served the population there, and Venice has always had that. But formerly, we really had some clinicians that got out there in the mid-'80s, and we've always welcomed them in to do comprehensive medical care as a community clinic and an FQHC. Trauma-informed care, again, it's a word that we use now, and the clinic was built on that. It's not trauma-informed, it's just Venice Clinic. So before these terms are coined, they're in-baked into a clinic like this where folks feel comfortable to come in because the security guy is nice out front. We try to offer a lot of services in-house, like shower, clothing, food, transportation, and we have lots of locations where people can come into. Most importantly, we get out and do street medicine. With any given day, we can count this differently, but let's say 9 different teams, and we have drop-in centers, different access points. We have mobile units that are out there, so a lot of things that are not traditional classic street medicine, but a lot of ways to offer a progression for patients to come in. A neat infographic, but I don't think I want to spend too much time on this other than there's a backpack and there's a guy without a mustache there. I don't know what's going on with that. Somebody can come and hack one in there for me. But this is how we started street medicine at Venice Clinic. Backpack jumps in the field with a social service agency, Dodge Caravan. And we can be as mobile as you need to be, but not providing a lot of services other than I'm the face and the access to medical care, and I can do a full good faith exam on that patient and welcome them in as a patient to the clinic. But maybe not do full scope care on them there, but they are our patient. We have them, they own us in LA Care or whatever, whatever plan it is. We own them, they own us. I'm gonna flip that around. We have access centers, we have drop-in points. But along the way, we realized that a neat little van that's not too big, not too little, that we could build this and provide them with a little more access to privacy. Maybe it was just a sneaky way for me to get nursing into the field because they wouldn't send a nurse with me, but no, don't tell anybody at the clinic. It's a way for me to leverage more people into the field when I say I have a project and a vehicle and it's cohesive. And we get lab draws and we get more wound care delivered out there, and it's a place that we can dispense meds from because it's a proper site. One more thing I want to say about this slide is Brett and USC are teaching from an institution part. We are teaching from a street experience point of view, and I think I don't know how old Absalon is, but Dr. Galat is one of the DHS doctors who in LA County is doing their street medicine program, and he was at Harbor Family Medicine doing his rotation. He said, "Can I come and hang out with you in street medicine?" So now we'll call it a training program, but it's just a shadowing experience, something just to see, yes, you actually saw a patient in the street, just one half day. We got Dr. Sharon from the legend from DMH. Hopefully he shows up at some point in something cool here. Come jump in the van. And then we formalized this into a much more cohesive training program. So Brett can send me PA students, and they're the best students in town. I'll just tell him right now that none of the other PA students are as good as Brett. No. It's a place where people can have a rotational experience to see street medicine, and we're really proud of that. So none of this is any good without me telling a patient story. Uh-oh, did I go? No, I went up and back. There you go. This is Princess. This is one of our African-American female, big, bold, and beautiful, early 40s. One of our very sort of typical flamboyant street medicine patients. Her name's not really Princess. She has another Prince reference. She's a big Prince fan, but I'm not going to use her real name. But these are really her toenails, and yeah, they're painted red. And she was very proud and beautiful, but they're curling into her toes, and they actually really hurt, and she can't actually physically get down because So she appears to be 8 months pregnant because she has a uterine fibroid that is about the size of 8 months pregnancy. And she has an umbilical hernia that's about the size of a lemon. I'll use the food reference of pathology systems here. So, you know, she can't get to her toenails. She's very involved still in her mental illness at this point, too. So she's disorganized. If I were to diagnose, I would say she'd have schizoaffective disorder. So she has a very strong mood component. She's labile. She's wild. She's gregarious and charming at one point in time, and at another point in time, she's very paranoid that these guys walking down the sidewalk are talking about her, and she gets in a lot of scrapes. So during the time that we were engaged with her, she got beat up twice because, you know, she'd be part of some interaction, and she'd get beat up, and we'd have to bring her. She'd go to the hospital, we'd have to bring her in. So in this process, she's out there. She doesn't really trust anyone. And this is where we really get involved with our social service agency team, which is our partnership and our model. They're out there for weeks getting to know her, and they say, hey, Dr. King will cut your toenails. And this is one of my residents. I'm making him cut some toenails, and this is a nod to Jim O'Connell. Is start with people's feet and work your way up. So that's an engagement piece after they engaged with her for several weeks or months. And that's like, sometimes you engage with someone in 2 seconds and it's love at first sight with that person out there, and you're great friends forever. Sometimes it takes a couple of years. And we could just do this. We could take care of her toenails for the first bit of time. And then for the next several months, we could get to know her a little bit. And I bought her a lot of coffee, and we're talking about interesting things out there. And then I say, what do you want to get done? She wants to get this hernia fixed, not the uterine fibroid. So how are you going to get that fixed? And we talk a little bit about her emotional state because we're at that point now. We can talk about things. And I say, well, if you take some of these little pills, you can be more organized and you can maybe make it through one of these surgeons' office visits because surgeons can be quite cantankerous. And she takes a few of these. She gets a little more organized. She's still on the streets. And then we introduced this idea of the long-acting injectable antipsychotics. And right near the promenade in front of McDonald's, I just give her a shot in the arm, and she does start to come down to a more organized state. I get her into a shelter, and I warn the whole team, because we're ready to get that hernia fixed and take that fibroid out. It's going to take us actually 6 months, 12 months, with good luck, to get the surgery done. She's in the shelter. Then we got to get her insurance changed over to me as a primary, because I've been actually seeing her. I've just been seeing the patient. I haven't worried about insurance, but we've got to get insurance done at this point. And that's what the conference is about. So getting her insurance changed over to me as a primary, then making the referral and waiting for that electronic pushing electrons around the universe job that we do sometimes. Go down to my downstairs department, over to the med point, and over here, and then at some point, she's got a surgical appointment with one surgeon. She goes in there, the case management team doesn't know she's there, and cut me off in time when I'm getting short here. And she gets kicked out of, we're short, she gets kicked out of the surgical appointment. So to make this very short, with a personal heroic effort from numerous people, including a nurse who took her to a lot of these things, this is not an effort that can be replicated for lots of people. We get her surgery done. She gets kicked out of the shelter. She ends up at her mom's house. She's lost a follow-up 6 months ago about it. So it's an upward trajectory with spikes. I will find her, but we don't know where she's at right now. We did get a lot done, and we didn't quite have enough services to bring it all home. So it's all the case management. It's all the wraparound that makes this happen. And so there's Princess. Thanks. Okay. Last slide.
Thank you, Dr. King. Thank you. Thank you both for the...
Sorry, we used up all.
No. I think that story was an important way to spend our time. We can talk about all of the theories and ideas and ways to approach this, but without really being able to put people behind it, doesn't mean so much. So we're going to shift over to policy a little bit and close out the presentations with Cynthia.
Good afternoon, everybody. I'm Cynthia Carmona. I'm with Carmona Insights now, but very recently was with LA Care Health Plan, and so was involved in a lot of these discussions. I know Brett and I were in a lot of meetings together. And I'm so honored to be able to work with providers like this. So you guys have heard yourselves today, the amazing work they're doing. And what is the challenge that folks like managed care plans now have to face when trying to help solution with providers like this and with all the things happening in the state kind of policy ecosystem. So I'm going to talk a little bit about that today. How many managed care people do I have in the audience? Yay, there they are. Oh my gosh, there's a few of you guys. So just big shout out to my managed care peeps, because I know they're all working really, really hard too on a lot of different things to try to make things happen. And I wanted to make sure they got a little shout out. So, and I know they all feel just as honored to be working with folks like this and are really excited to do that work. So I'm going to talk a little bit about some of the trade-offs that we've seen with all of the changes that have been going on. So you'll see there in the Navy, those were some of the activities I know that LA Care engaged in, at least, before kind of CalAIM and the Street Medicine APL and all those other things. Some of the things that we had looked at and thought, what can we do outside of just, formal Medi-Cal program to try to impact what was happening in LA County around homelessness. So we did engage in some pilot programs where we were paying for room and board for a small subset of our membership, I'll admit. We worked really, really closely with LAHSA, the local housing authority, on some data exchanges, which I will tell you, with HIPAA and everything, was a whole process where people were meeting the other people on street corners with flash drives to help make that happen. And so that was something that really we were working on. Grant making was obviously something our community benefit office was always looking at. We did some recuperative care pilots that were small, and obviously during the pandemic, we did some work with LA County around transportation to isolation quarantine sites for the homeless population as well. So then you flip over to the government program side, right, where things start to get a little bit more formalized in the Medi-Cal program. We have enhanced care management comes up. Community supports we've talked a lot about. Some of those incentive programs that Brett mentioned. And he also mentioned the street medicine guidance, the APL that was recently released. So it's just to kind of demonstrate that kind of the trade-offs, right? So pre kind of the formalized stuff, there was a lot of freedom for plans to go out there and kind of mess around to see what worked, right? And to find those promising practices and invest in them. But, the scale was always smaller, right? Because you didn't have the big Medi-Cal dollars to help with that. And so, the room and board one is a good example. I think we helped about 350 members over the course of about 3 to 5 years for permanent supportive housing. And so 350 members out of 69,000 people experiencing homelessness is not huge, but it was, something to look at to say, what can be done here and what are the outcomes. So you switch that over to the government programs, the resources are much more. You can impact many, many more individuals, but it comes with all of the kind of oversight and regulation that comes with operating a managed care plan in the Medi-Cal environment. And so that's something that we're always kind of very frequently talking with our providers about and other stakeholders so that everybody understands kind of the kind of standards that the managed care plans are held to. So when we're investing in a lot of these things, we always have to be thinking about that, right? I would say even with the incentive programs, I know some of you are knowledgeable about those, they come with a lot of metrics, right? So you'll find that many, many dollars on the table, but there are some real expectations in terms of outcomes. And so the plans are always trying to kind of triangulate, right? So So that's really kind of what I think has been interesting and important about the role that managed care plays in stuff like this, because we're trying to realize a vision at the state level, and also helping to work with the providers that are on the street, right, that are dealing with the realities of the operationalizing of that, and how does the plan kind of make those two things meet in the middle. So I know that Brett mentioned HIP, so I wanted to throw this slide up here. LA County has done a lot of work organizing around the Housing and Homelessness Incentive Program. And I would be remiss if I didn't mention the efforts of Allison Klurfeld, who's very well known, up and down the state with her work on homelessness, Carly Goldblatt from the HealthNet side, really organizing that group of stakeholders, which included all of our plan partners, the Department of LA County Department of Health, but also mental health, the county CEO's office, lots of folks coming together to establish these priorities in LA. And again, these are all very specifically kind of tied to those metrics that the department established that they wanted to see in terms of outcomes coming out of HIP. So you can see the 5 focus areas there, the first being infrastructure, right? Because you don't do anything without thinking about the data exchange. Workforce is also a piece of that, as an underlying theme of, I think, all the conversations here. Street medicine was something also that was really important. So we're looking at grants there, TA, technical assistance to street medicine providers, what kinds of other resources, if it's not coming to them in a PM or a fee-for-service, what else can be provided to help that, make that successful. CalAIM, ECM, and CS, I don't think I need to go too much into that, but it's just how can enrollment in those programs be enhanced? But the 2 that I want to really focus on are these 2, where there was a lot of discussion around these 2 strategies, which were a little bit different and unique. And I think regardless of the metrics that we knew we were going to be beholden to, we knew that housing stock had to be addressed. Housing availability itself had to be addressed, right? If we're going to have housing navigation services as part of community supports, if that's an 18-month service, right, how do we ensure that there is a place for them to land? And so we all talked and worked together, especially with the county CEO's office, who was really helpful in this research. The unit acquisition strategy, which was a way for us to get around the prohibition on room and board, where we were saying, let's think of the other costs that landlords have that aren't rent specific. That could be an incentive for landlords to make a more long-term commitment to make units available. So that's something that is being looked at, and we're right in the middle of implementing an agreement with the county CEO's office around that. And then also the ADL expansion. So something that we talk a lot about in LA is board and care plus, right? People need a place to stay, but there's a big chunk of individuals who need a place to stay and like a little bit more help, right, than just, a place to sleep and where to get some meals. And so what can we do to make more of that available? And so this is really looking at providing some funding out of HIP around like field-based assessment teams, because you've got to get the assessment done to get them eligible for the reimbursement. And then also finding those facilities and helping them to enhance what they're offering to make it a place where folks who are struggling with activities of daily living can come and stay and get a little bit more assistance. So those were the 2, I would say, like a little bit more unique approaches that we decided to really heavily invest in that discussion with the stakeholder group that we were working with. But yeah, just wanted to point that out. That was a major effort last year and is still ongoing. Here are some other kind of, I call them managed care considerations, and I just throw this up there. All of these things that I mention up here are in various stages of kind of being worked out, right, amongst the managed care plans. So they're all kind of little puzzles within themselves when you're working in managed care. Again, it's that intersection of the regulatory environment, the state's vision, and what the providers are really dealing with on the ground, and how do we make these pieces work, right, to help accommodate all of that. So we talked about the structure and model. I know Brett first mentioned, fee-for-service and PCP assignment. So like, what is the best model that's going to work best for that particular provider, right? And how can we kind of tweak whatever those regulatory requirements are to make that possible. I also want to shout out DHCS. They've done a lot of work, and we're really receptive to managed care feedback on a lot of these kind of regulations and how to make things a little bit more workable on the street medicine side. Provider vetting, so there's a lot of guidance in the APL about how to vet providers, what managed care plans need to be thinking about in terms of how to credential a provider who's going to be doing street medicine. What I thought was interesting about Dr. King and Brett was that, Dr. King talked a little bit about that mobile model, right, and what the mobile unit brings to his work. And Brett talked a lot about, the benefits of not having that mobile unit and what that means. And so, that means different things from a managed care plan credentialing perspective, and what's available to that member. So thinking that through very clearly. The other thing that Brett mentioned and touched on was all the services, right? What's everything that's being brought to the member? So ancillary services. What are the current structures in place for providing all of those required services under Medi-Cal, whether it be transportation, whether it be meds, right? There are, I think many of you in this room probably know, there are many different ways that all of those services are structured. And so kind of pulling all of those pieces together can mean working with different units within the department, different departments altogether sometimes. So how do you kind of tease apart that, knot of administration, for lack of a better word? Health information exchange, always a big one. I think we talk about it a lot in all the areas. But, how do we make sure that that's available to providers while they're on the street? There are, PCPs who are interested in understanding, if someone is providing a service to their patient, you saw this person, what did you find? Did you draw labs? What were those results? And so that's something that we've thought about and we fielded a lot of questions about. Specialty needs. So this one has come up quite a bit. And that is, we see somebody on the street, Dr. King talked about this in his case study. When you do find somebody who really needs some specialty care, what then, right? How do we deal with that? And what are going to be the impacts of that? If we're really going to scale up the street medicine model, how does that impact just specialty care in general in terms of network adequacy, in terms of access, right? How do we make sure they can get to the specialty care appointment, the surgery, whatnot? And then the last thing I'll just put there is range of capabilities and kind of range of models, right? So you've heard here today from two providers that do similar work, but you've got the mobile unit in there a little bit more on one of them. There are others that had come and talked to me about, we're gonna have an army of vehicles and we're gonna do mobile cardiology and we're gonna build a building that's just for people experiencing homelessness who need specialty care. So plans are really seeing, I think, the environment that Brett mentioned, where there's all this new opportunity, has really created an environment where there's a lot of different models, there's a lot of different offerings. So how do kind of the plans wade through that to figure out, okay, how are we gonna make sure that this gets done appropriately, timely, it's paid correctly, the structures are there. So just something else to think about when we think about what everyone is presenting, and how do we kind of sift through that and think through how we're going to be able to make as much of that happen as we can. So that's just to kind of give you a little taste. Again, it's not to kind of be the managed care Debbie Downer of the day, but because the plans are really trying to work through it, but they're thorny, and you got to spend a little bit of time to really work those pieces out. And so I know a lot of people that are really working hard to do that. And so with that, that's the end of my presentation. So thanks for having me, and I'll turn it back to Erin.
Thank you all, and thank the three of you. You also did, unknowingly, a good kind of wrap-up tying the three together, so I won't spend time repeating that. I will just say that one of the things that really resonated with me was just having to find creative approaches to care, both on the services and policy side, and kind of that all coming together right now and coalescing, particularly in LA, but across the state of California. I'm going to use my poetic license, but moderator license, and keep my promise a little bit about having more of a conversation at the end. So I'm going to skip over my questions. Are there questions? What are you guys thinking? It's a lot to process. We just threw a lot at you, but any top of mind questions that you have for the last couple of minutes that the panel can answer? Yes, please.
I have a follow-up question to the.
Oh, there's a mic for you.
I have a follow-up question to Ms. Carmona, what you were talking about in terms of sifting through. Like it sounded like there's all these different kind of providers coming at you, like, hey, we want to do this thing. We think our ideal is brilliant. And I think one of the questions that I have is like, how is your decision making informed by people experiencing homelessness? Because I feel like the people who know how to write a good grant and like put on a nice dog and pony show are not always actually the same people who have the trust of the community.
Right.
And I just realize it's very tricky, and just curious, like how, I'm just thinking about like Black, Indigenous, and other people of color living under bridges. Like, how are they informing your decision making?
Yeah.
Do you know what I'm saying?
Yeah, I think that is a really excellent question, and it's tough. It's tough to get that when you're sitting at the health plan trying to make some of these decisions. I would say that we were lucky at LA, and again, working with our plan partners who had experience, with their provider networks, where we kind of knew who a lot of the players were, the folks that had been around, maybe some of the other folks who had been a little newer. And we had spent time, as I mentioned, like in a lot of the meetings with Brett and some of the other stakeholders, but also over the years through community benefit too, and some of the grants that we had done. Our community benefit office, I think it's safe to say, has pretty rigorous follow-up and reporting standards. And so when somebody comes to us with like this brand new flashy thing, and we've never heard about that brand new flashy thing from them before, right? And this is Medi-Cal, this is a Medi-Cal managed care plan. So this has been our population forever. So there's a lot of due diligence right before you pull the trigger on something like that. And I would say that a lot of the folks that have come forward with some more of the flashier things, we haven't gone full bore with folks because we do want to do a little bit more due diligence, learn a little bit more about exactly what they're thinking, get a little bit more information about their experience thus far. And so, the one thing that I would say is, at least at LA Care, is that we had member advisory committees in every spa. And then there's like a central member advisory committee made up of participants of all those committees. I'll admit, you're probably not seeing a lot of people experiencing homelessness in those committees, but it is LA Care's attempt to try to get more feedback from the members about what they're really looking for from the plan. And I know a lot of plans do that. But I would say, so it's kind of a mix of hearing from the member advisory committees, doing that outreach that we've been doing for a long time, so we kind of know who those players are, and doing a lot of due diligence with the new folks that are showing up. So it's not an easy decision to make by any stretch, especially when we're looking at doing so much new stuff very quickly. But I think we're doing the best we can with what we can know at the time.
Can I make a comment about involving people who are experiencing homelessness in these decisions? And I think if you really want to do diligence, you have to go out onto the street, and you have to talk to the people. And that includes if you're employed by a plan. Because when we involve, like in other situations, if you're working with Indigenous people or LGBTQ, you talk to them and they're part of that community. But for some reason, and there are convenient reasons for this, for people experiencing homelessness, we allow people who have lived experience, who were formerly experiencing homelessness, to represent them. And they should absolutely be at the table. But if we really want the voice of the community, it can't be somebody that was formerly part of the community. Just like I can't represent the student body because I used to be a student. And so, and if you have lived experience and you're no longer experiencing homelessness, it keeps them in this really horrible limbo where they're not fully housed and they're not fully homeless. And so I just encourage you to get out onto the street. You're welcome to come with us.
Yeah, and I would say one of our medical directors just recently, I think, went out with you.
Yeah, he was great.
Yeah.
When I heard Kevin Burns was
Kevin.
LA Care, I said I got his cell phone as soon as I could, and I got him in the van to do a ride around.
Yeah.
So that's
Yeah.
not him spending time with a homeless person in the street corner, but it's, he at least got to go around with us and see what we do.
Yeah.
So go see what they do. Jump in the van with them. See if they really have any project, so.
And I see a number of other hands, and I am getting the flag. Oh, no. So I think it's a glimpse of what we could continue. I think we can stay and have a couple of offline questions that we're happy to answer for the next few minutes. But in terms of the group, just thank you for your engagement and listening and processing. I know it's a lot of information, and it sounds like we could have made this a 2-hour session. And so there's a lot of follow-up. We scratched the surface, and thank you for the engagement. Also, evaluation through the app for this. Please don't forget. And yeah, we'll stick around to answer some other questions. And if you have other follow-up, we can certainly share our personal information. Thank you for joining us.